Hey y'all, welcome to the NCMHCE Bible Prep. I am Lourdes, and today we're diving into the intake and assessment process, one of the most foundational areas in clinical work and also one of the most misunderstood sections of the exam. I created this to help bridge the gap between textbook knowledge and real clinical logic. So let's get into it. We always start with the biopsychosocial interview. This is where everything begins. This is your intake portion. This is where you have an opportunity to gather information about the client's biological, psychological, and their social world. Each domain gives us clues. When you're at the intake, it's not about just checking boxes. It's about seeing the whole person in context. The biological domain assesses their medical history, whether they are on or have used medication, their health history, and their physical functioning. The psychological domain explore the presenting problem and history of any mental illnesses or mood symptoms or how they are functioning cognitively and whether they pose an issue to themselves or others. Now, their social domain examine their family relationships, how they see themselves in the world based on their cultural identity or sexuality, their education, what they do for work, and spiritually, and if they have any trauma history. Now, we're going to talk about our assessment tools because this is important when you are thinking like a clinician. These are your clinical sidekicks. You do not have to memorize every question on the PHQ-9 or on the GAT-7, but know specifically what each one measures and when to use it. The exam loves to throw curveballs to test you on matching tools to the problem. For example, if you're screening for depression, always remember PHQ-9 because it is a standardized measure of depression. It measures the severity and how to keep track of the symptoms over time, and that helps guide treatment decisions when you have a client that is exhibiting depression. Next, we have an anxiety assessment, and that's where the GAT-7 comes in. It's quick, is effective, and it measures anxiety, and it helps you monitor treatment progress. We have the ACE questionnaire, which identify adverse childhood experiences for evaluating trauma, along with the PSL-5, which measures trauma in adults. For substance abuse screening, you have the audit, the DAS, and the CAGE. Those are provided structure approaches to identifying problematic substance abuse patterns. Now, the next thing you want to focus on is building rapport because building rapport is not about being nice. It's how we open the door for healing. You want to validate, reflect, and show up for your client without judgment. Some clients come in guarded, and that's okay. Remember, as clinicians, our job is to make them feel safe enough to be real with us. So when you use phrases like that makes sense and it's okay to feel that way, that normalizes the client experience. You have to practice reflective listening. You have to either repeat or paraphrase what the client says to demonstrate your understanding and you're paying attention to them. And then you have to maintain a non judgmental stance. So you have to avoid showing shock or making assumptions about client experiences or choices. Remember, report is key. And the most important is do not push too hard early in the therapeutic process. You have to allow the trust to develop naturally. You have to respect their boundaries. Now, let's go deeper into what kind of clients and what works for one won't work for the other. So, the next few slides, I'm going to break it down from personality disorders to trauma survivors so you can build trust on their terms. Okay, so bear with me. When you have someone that have an anxiety disorder, you must normalize their fear. You have to speak calm, and you have to give them control, give them permission to take breaks. When you are working with anxious clients, Practice giving them a predictable environment that helps them feel safe. Validate their experience by saying things like, "You're not alone in this. It's okay to feel anxious." Remember that over explaining can actually help reduce their fear by eliminating uncertainty. For depression, it's okay to not be so apt to fill in the space. Allow allow the client to process their thoughts. So allow them to have quiet moments so that they can process their thoughts and what it is that they're saying. Expect them to have low energy. That's a part of their diagnosis. You have to understand a flat affect and minimal responses are symptoms. That doesn't mean that they're being resistant to you. Now, always acknowledge their effort, because them showing up in and of itself is an achievement. And you can say something like, "Okay, you showed up today." That takes courage. That takes strength. When you work with depressed clients, focus on safety and dignity. Validate the heaviness of their experience with statements like, "It sounds really heavy. I'm here to carry some of that with you." And remember that depression often makes communication more difficult. So patience is essential when you're working with clients that are depressed. Trauma survivors. I want to emphasize the importance of allowing them to have autonomy. That's number one when you're dealing with trauma survivor. And you also have to create a space where they feel safe. So when you first get a client or you're working with someone experiencing trauma, understand that you have to rebuild their trust gradually. You have to ask permission before asking personal questions or changing topics or even allowing them to relive their trauma. And explain your transitions. Be very predictable to help them maintain consistency. Always avoid asking for traumatic details too early on in treatment, as that can re traumatize them, and we don't want that. As clinicians, we have to build a foundation of safety first. Now, when you're working with individuals with eating disorders, remember these clients often fear judgment or a loss of control. So, approach clients with eating disorders with particularly sensitivity to tone and language around food, weight, their physical appearance. Focus on building the therapeutic relationship based on trust rather than compliance with treatment protocols. So pay attention to nonverbal cues that may indicate their discomfort with their body or anything related to, topics of food and eating and appearance. And always try to acknowledge their ambivalence, like their internal conflict and what it is that they experience. Tell them things like, "I hear that part of you wants help and another part may not be sure." You can say things like that because that lets them feel validated, lets them feel safe and seen. And it's important for you to create a shame free environment. Emphasize that your space is not about shame, it's about safety and honesty, to build that therapeutic support with individuals that experience eating disorders. Now, for therapy resistant clients, you're going to have some clients that do not believe in therapy being effective, or they may not believe in your skills or your education. So, what you have to do over time is explore their belief system. Ask them, what do they believe in, and build from there rather than imposing your therapeutic framework. And acknowledge their resistance, again, without judgment. Reflect on their hesitation without pushing for immediate change or acceptance. And when you work with their clients like that in therapy, sometimes that may be even court mandated clients. Always offer collaboration instead of trying to fix their presenting problem. Position yourself as a consultant, not an expert that will solve their problems. That way, You're validating their skepticism, and you're opening the door to helping them to find value in the therapeutic process. Now, this is important. As a therapist, mindset is essential, rapport is essential, but it's not friendship. Never blur those lines. You're not there to be liked by your client. You're there to build trust, safety, and the therapeutic alliance. You can be warm, you can be honest, compassionate without people pleasing. You can hold space without carrying the weight home with you. So think of yourself as a mirror. You're reflecting, you're steady, you're present, but you're not absorbing. And on the NMHCE, this is the most important mindset to have. If a vignette shows a client who's hesitant or ashamed or they're scared, usually the correct answer will be the answer that is built around establishing rapport and creating a safe environment. So, another mental note is when you get into the therapeutic process, you don't have to assign homework. Don't jump into confrontation. You always start with safety. You always start with trust. Maintain those professional boundaries and be firm, be gentle, be a mirror, not a sponge. So that way you can maintain your own emotional boundaries to prevent burnout, and you can be able to have objective clinical judgment. Now, this part is about using the DSM-5. Diagnosing is not guessing. It's a match between what the client presents and what the DSM says. Always rule out, and I'm going to say this again, always rule out medical or substance abuse cases first. Then, as a clinician, you have to use your best clinical judgment plus the tools to land on the correct diagnosis. And if you are unsure, because sometimes that happens, you don't always have to be sure. This is why you use the other specified. That is your friend. Okay. And if you go through the DSM-5, check on any diagnosis. You would always see they have a portion at the bottom of the paragraph that would say other specified. For example, let's talk about a diagnostic example of how to apply diagnostic processing using clinical reason. Let's say the client presents with low mood, poor sleep, loss of appetite, and guilt, and it's been going on for 3 weeks or more. Automatically, I want you to think, should this be should you think about major depressive disorder, and you need to match the client's symptoms to the DSM-5. For example, for the DSM-5, they need at least 5 symptoms, and one of them must be either depressed, mood, or loss of interest. The symptoms have to happen at least 2 weeks, and they must be causing an impairment in the client's life, whether it's socially, emotionally, or functionally. And before confirming the diagnosis, do your rule outs. Make sure there's no substance abuse use. So it's not substance induced. No signs of mania. Because if there's a sign of mania, then that may lead us to bipolar. And you have to make sure it's just not grief, because the presence of guilt and impairment pushes towards major depressive disorder. So in this case, the diagnosis, MDD, will be on the exam, and this is how you would walk through it mentally and clinically, not just guessing labels. Okay. Now, this is important. This is the mental status exam. This shows up in a lot of vignettes. It's a clinical snapshot, what the client looks like, sounds like, and how they're thinking. Do not just memorize the terms, know what they mean. For example, if a client has pressured speech, always think mania. Flat affect, think schizophrenia or depression. So your mental status exam are observable characteristics, clinical significance like their hygiene, and always document your approach objectively, okay, without judgment. And you have to know how a client present in your first session may change from the second, third, and so on and so forth. And if you see a deterioration in how they present themselves, that can be an indicator of their mental health status. So when you talk about the behavior and psychomotor activity, as clinicians, we need to know whether our clients appear agitated, hyperactive, slowed, or catatonic. Those observations provide important diagnostic clues and help track treatment progress over time. So, look at how they present themselves, how they move their body. Are they using gestures? Are they restless? Are they manic? Now, in the mental status exam, speech is important because this is how we document their patterns objectively, noting any changes from baseline and considering cultural or linguistic factors that might influence their presentation. So, look at how fast or slow or pressured or even their volume, how loud, soft, or mute. And if what they're saying is coherent, is it slur? Is it tangential, like going off topic? Those characteristics provide valuable diagnostic information. If a client speech is pressured, that often indicates mania, while delayed or slow speech typically means depression. Slur speech may indicate substance abuse or being under the influence or some neurological issue. Now, when you think about mood, that's how clients feel subjectively, their state of mind. And this is from the client's own words. So when you document it, use quotation marks. Ask about what mood directly with specific questions like, how would you describe your mood today? What emotions have you been experiencing lately? And look for clues in words like sad, angry, empty, anxious, or euphoric. They How they report their mood helps guide your diagnosis and your treatment plan. Now, for affect, this one is important. I remember getting a question on affect. Know what flat affect, blunted affect, and constriction affect means, and label affect, and know how the affect needs to be appropriate based on the context of the conversation. So, for example, flat affect is when there's no emotional expressions. I like to think about characters when I think about flat affect. So, something that will remind me of a flat affect will be Daria. If you remember the show Daria from MTV, she always gave me a flat affect. She showed no visible emotion expression. And when a client has flat affect, it's usually pointed to depression, severe depression, or schizophrenia. Blunted affect is a reduced in emotional expression, which is common in schizophrenia and some individuals that have personality disorders. Constricted affect is reduced range of emotional expressions. Some may indicate depression or anxiety disorder. An appropriate affect is emotional expression that's rooted and reported in the conversation and content. So that indicates that they're functioning at a healthy mental level. And label affect is how they shift their emotions. And it's common in bipolar disorder or borderline personality. One moment they're all the way up, and the next moment they're like down. So it's just like one or the next extreme. The thought process is how their flow of ideas, is it coherent, is it going off topic and is never returning to the main point, is it circumstantial, do they have loose associations, do they have a flight of ideas, their speech, is it rapid? And this is important because thought content will let you know if a client is having suicidal ideations or homicidal ideations, if they are thinking about death or ending one's life, if they require immediate assessment of plan and intent. So always document specific statements and their risk level. If they having delusions or a fixed false belief that's not based on reality, and it's common in individuals with schizophrenia or any specific delusional disorder. If it's grandiose, I like to think delusions like, I don't want to be sued, but a specific rap artist that goes off on Twitter. I don't want to I don't want to be sued, but you get where I'm going. Allegedly, right? And then we have obsessions. If they have any intrusive, unwanted thoughts that can cause them distress, and paranoia, are do they have excessive suspension or an intend harm to themselves or others, because that can also indicate psychotic disorders or severe anxiety. Hallucinations is important because if a client reports having auditory, visual hallucinations, hearing or seeing things or sounds that is not there, these can point to, if it's not substance induced or use, it can point to specific personality disorder like schizophrenia, and different types of hallucinations suggest different conditions. Like I mentioned, auditory hallucinations are common in schizophrenia. Visual hallucinations are substance abuse or neurological condition. Tactile hallucinations are from withdrawal substance. And a combination of auditory hallucination and bizarre affect strongly suggests schizophrenia or another psychotic disorder. Judgment refers to the client's ability to make sound decisions and understand consequences. It helps them to reflect how well they can apply insight to real world situation. This is important because as a clinician, we have to know and understand that poor judgment often manifests as risky behavior and poor boundaries. And it can indicate conditions like mania, substance use disorder, or certain personality disorder. So our approach will evaluate judgment through questions about hypothetical situations and by reviewing recent decisions to consider whether the client can identify risks and benefits of their choices. Cognition and orientation checks for alertness, their attention, their memory, whether they are experiencing delirium or dementia. The mini mental statics exam is commonly used for more detailed cognitive screening, especially with older adults. This is important because sometimes your client may not understand why they're being assessed and the purpose of the meeting. So it's important to ask a client if they know who they are, if they can identify others appropriately. Do they know where they're at? Do they know the facility name? Do they know the day's date, the month, the time? Now, the exam will absolutely give you dual diagnosis scenarios, right? So your job is to tease them apart. And when I say tease, I mean know what came first, what was primary, and how they interact. If you miss one, you miss points. It's important to use timeline tools and client insights to make clinical calls. Okay, so know what a dual diagnosis or comorbidity is. It's the presence of two or more mental health and substance use disorder in the same person. For example, depression and alcohol use disorder together, or PTSD and generalized anxiety disorder. And symptoms often do overlap, and that complicates diagnoses. So you must, as a clinician, you must develop a treatment plan that addresses all the conditions for effectiveness. One condition often exacerbates another. So if an individual is having depression, and they're also using alcohol, it can make their system of depression worse. And as a clinician, our goal is to help our clients recover. And when you integrate the treatment, it improves their rate of recovery. So, certain mental health conditions co occur because of overlapping risk factors. So, when we recognize these patterns, it helps us conduct more thorough assessments and develop comprehensive treatment plans that address all presenting disorders. The most common combinations that we're going to discuss is depression and substance abuse, which is how low mood, isolation, sleep, and appetite disturbance combine with self medication with alcohol or drugs. Clients will often report drinking more when they feel depressed. Usually, depression developed first, and when you add substance abuse to the mix, to the mix, to the mix, it creates a maladaptive coping strategy. So, as a clinician, think about your approach. So, an effective assessment will be to screen using the PHQ-9 and use another screener for substance abuse, like the audit, the cage, or the DAS, and ask them timeline questions to determine which condition appear first. Like, when did this first start? How often do you drink? And then explore the patterns between their states of mood and the use of their substance abuse. And then you must create, along with the client, a treatment plan that addresses both conditions with sobriety as an essential component of the recovery plan. Because if they're sober, then they're more apt to recover from their depression. PTSD and anxiety is the foundation based on a trauma experience and anxiety underlining it. So when trauma is present, post traumatic stress disorder underlines anxiety. So, your treatment plan should always follow trauma informed principle. You have to address both the trauma and the anxiety. And typically, trauma and anxiety co occur. So, you have to use assessment like the PSL-5 for the PTSD and the GAT-7 for anxiety, along with questions about the traumatic experience that still affect the client. ADHD and depression, or ADHD and anxiety. So, as a clinician, we have to realize that ADHD is a chronic um, it's a chronic diagnosis, and the onset is childhood, while mood disorders tend to be episodic. And developmental history is crucial for accurate diagnosis. So, if a client presents with inattention, forgetfulness, and they cannot distinguish between conditions, those are challenging to overlap. So, the best approach would be to use Connors or the Vanderbilt scale, which is for ADHD. And for the depression, PHQ-9, the anxiety, GAD-7, and explore the symptom of onset, the duration, how long has it happened, and how they've been functioning over time. And when a client may experience ADHD, depression, or combined with anxiety, vice versa, they may require both medication management and therapy targeting their executive functioning skills, their organizational skills, and their mood regulation. Borderline personality disorder and depression, or BPD and PTSD. So, as a clinician, you should include the SICD 5 for personality patterns, always depression, PHQ-9, and PCL for trauma. Your key questions should include: do your emotions feel too intense or too hard to manage? And do your mood change usually are triggered by relationships? And for BPD, you're going to need specialized treatment like DBT therapy because it addresses trauma and emotional regulation, and realize how symptoms are often triggered by their interpersonal situation, which is distinguishing from pure mood disorders. So, if someone is emotionally dysregulated, they will have intense mood swings, and they may sometimes want to self harm, like cutting, or they'll have behaviors that are common with this specific combination. Bipolar disorder and substance use. This combination presents as mood swings with impulsive drugs or risky behaviors. Your assessment should be the mood disorder questionnaire, the MDQ, or mood diary with substance use screening tools like the DAS or the audit. And your critical diagnostic questions is: do you ever feel like you're on top of the world? And have you not slept for days? When someone has a manic episode, they have a decreased need for sleep, they're more impulsive. Often, they may use substance abuse, and that increase their mania, and it may increase their depression. They become emotionally withdrawn, and they use substances to cope. So, as clinicians, we must adapt a integrated treatment to address both their mood stability and their substance recovery. OCD and depression is when they have specific obsessions alongside feelings of guilt, shame, and hopelessness. They often report clients feel stuck in their thoughts and behaviors, which contributes to the depressive symptoms. And OCD frequently causes depression due to a significant impact on their daily functioning and quality of life. As a clinician, how we assess should be to use the Yale Brown Obsessive Compulsive Scale, the PHQ-9 for depression, and we have to ask them questions about their intrusive thoughts and compulsive behavior. Our treatment plan should address both conditions simultaneously, with early focus on the obsessive thoughts using exposure and response therapy techniques. Schizophrenia and substance abuse presents with hallucinations, delusions, and paranoia, often accompanied by substance use. To manage symptoms or anxiety, we have to distinguish between the primary psychosis and substance induced psychosis. That's very important. Our assessment have to use the SCID for the psychosis symptoms, the DAS, or the CAGE for substance use. We have to carefully explore the timeline of the symptoms and how onset it is relative to the use of substance. For treatments, we have to, as clinicians, we have to know if the symptoms only appear with the diagnosis of using substance rather than schizophrenia. And you have to help the client seek, via referral, medical stabilization, followed by a reassessment for true schizophrenia. Clients with multiple diagnoses require a comprehensive risk assessment. So you have to include screening for suicidal ideation using the Columbia SSRS. You have to assess for self-injurious behavior, homicidal ideation, especially if a client is having psychosis, Clients often face higher risks of suicide, self harm, substance abuse overdose, and poor treatment adherence. That's why you have to treat together. 50% of treatment of dual diagnosis, clients struggle with consistent treatment management. And 2 to 3 times when a client has a co-occurring disorders that have a higher rate of suicide risk than those with a single diagnosis. And 30% have a relapse rate without integrated treatment. So that's how important it is for us as clinicians to screen for co-occurring disorders, because if we screen for them, we can provide an integrated treatment. And within that integrated treatment, that will help them to make positive strides towards their mental health. Now, another exam favorite is, where should this client go? Whether it's inpatient, intensive outpatient IOP, or residential. Ask yourself, are they safe? Are they functioning? Are they using substance? When in doubt, it's important for us as clinicians to choose the safest route and document why. It's all about matching the client needs to structure. Inpatient, I like to think in hospital. That's a mnemonic that I use. Inpatient care is in the hospital. Those are usually for individuals who have a suicide plan and intent, and they can have hallucinations, or they have an inability to care for their basic needs, or they have severe substance withdrawal requiring medical monitoring. So this is appropriate for clients with active suicidality, acute psychosis, danger to self or others, severe psychiatric symptoms requiring immediate stabilization or medical detoxification needs. This is the most intense. This is where a client needs 24/7 hospital-based care with medical and psychiatric staff, where they're going to need where they're going to need um, how you say a continuous monitoring, medication management, and therapeutic interventions. Residential level is a step down. This is appropriate for clients who are medically stable, but they still need some structure and intensive support. Usually, trauma survivors, clients with eating disorders, substance use clients after a detox before they go back home, and clients with chronic mental illness needing skills development. This is a living treatment facility, and it provides structured programming, and it's in a non-hospital setting, and it offers 24-hour supervision with less medical intensity and inpatient care. And programs usually last from 30 days to several months, depending on the needs of the clients and their progress. Intensive outpatient level of care is appropriate for those who need more support than weekly therapy but don't require 24-hour supervision. It's common for those with substance use, recovery, mood disorders, and eating disorder. It's group based care typically provided 3 to 5 days a week for 3 to 4 hours a day without overnight stay. So they get to go home. It combines group therapy, skill building, and sometimes individual sessions. And it usually lasts for 4 to 12 weeks with gradual step down in frequency as the client improves. Outpatient level is typically what we would do as starting out practicing clinician. This is individual therapy, our one-on-one session, which usually is from 45 to 60 minutes. It focuses on personal goals and specific treatment approaches. Then we have our group therapy, which is a part of also outpatient, a version of outpatient therapy, which is regular meetings with peers facing similar challenges, facilitated by therapy, and it provides support, feedback, and skills development in a community supportive setting. And then you have medication management, which is periodic appointments with a psychiatrist or psychiatric nurse to monitor medication effectiveness and side effects. It's appropriate for clients with mild to moderate symptoms who can function at home, work, or school with support. This level of care is flexible and it provides professional treatment, making the most common form of mental health intervention. This is how step down care should look. The most severe is inpatient psychiatric care. Then you will step down to a residential. Then you have our intensive outpatient care and then outpatient therapy. Once you know the diagnosis and level of care, you pick how the client is seen. That's where treatment modalities come in. That's how you know the strengths and limits of individual, group, family, couples, play therapy, and telehealth. The text will ask you what's best next. So individual therapy is one-on-one, is between the clients, is 45 to 60 minutes. It allows for personalized attention, confidentiality, and tailored intervention based on specific client needs. It creates a safe space for exploring sensitive issues. It's appropriate for depression, anxiety, trauma, and adjustment issues, clients needing privacy, complex grief, identity work, or personal growth. Group therapy is more structured and where you see multiple clients with similar struggles meet regularly with one or sometimes two therapists, and the sessions are usually an hour to 2 hours. They have peer support because in a group there's shared experiments amongst the 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 clients, and it allows an opportunity for clients to practice interpersonal skills in real time. And it is appropriate for individuals who are recovering from substance use, social anxiety, or interpersonal skills, grief support, and intensive outpatient programs use group therapy a lot. And is not recommended for clients experiencing active psychosis, paranoia, or suicide, as these conditions may exacerbate in group settings. Family therapy works with the entire family system and it helps to improve communication, reduce conflict, and support the identified clients. It recognizes that individual problems often exist within the context of family relationship and patterns. It's effective for childhood, adolescent behavior, family conflict, trauma, divorce, or blended family challenges. When family beliefs or cycles affect recovery, such as when an individual have an addiction or eating disorder. Couples therapy is for couples who have communication or relationship issues or recovery from infidelity or codependency or premarital counseling. I do don't recommend couples therapy if there is intimate partner violence or you notice that there's coercion like force present, as those joint sessions may increase the risk. Couple therapies addresses the relationship dynamics between two partners and how they communicate, build trust, and establish boundaries and conflict resolutions, intimacy, and connection. Play therapy is child centered. It is effective for children under 12 or those who have experienced trauma or children with behavioral issues, and they may or may not have limited verbal expressions to express their feelings. So the therapist observe play pattern, themes, and behaviors to understand the child's inner world, their emotions, and the intervention happens within the play context rather than through direct conversation. Telehealth therapy is appropriate for individuals with anxiety, depression, adjustment pandemic related trauma, social isolation, and clients with chronic illnesses or disability that makes traveling to an office location difficult. Um, it has its advantages because it allows accessibility for clients in remote areas or those with transportation or mobility issues or individuals that have busy schedules or who prefer to do therapy in the comfort of their own home. So this therapy is done via a secure video platform and it allows clients to receive treatment. So for this is important as clinician to consider ensuring that the client knows to have a private space, a stable internet connection, and this is not ideal for clients needing physical monitoring or those that are in acute crisis. Multimodal treatment combines multiple therapy formats to comprehensive care. It's common in higher levels of care, like intensive outpatient programs, and is particularly effective for substance use disorder, eating disorders, or adolescents with multiple systems involved. And the combination of modalities create a robust support structure addressing individual, interpersonal, and systemic factors. So, as clinician, you have to know when to select the right treatment, assess if the client is safe, whether they can participate in a group setting, or if their condition requires privacy and focused attention of individual therapy. You have to know their support system, whether their family members or partners are contributing to the issue or could be a part of the solution. And if there are, then that's where you will involve either family therapy or couples therapy. And then you have to consider the client's age, their developmental stage, um, and then their factors for accessibility. Do they have access to transportation or any scheduling challenges? Or if they need something more flexible, and then their cultural context, how their culture and their values might affect their preferences for individual versus group or family involvement. Now, these are some case example. If a 15-year-old boy is acting out at home and school with overwhelmed parents, they all will benefit from family therapy combined with individual child therapy to address both systematic patterns and personal development. Substance use recovery will be for an individual who is abusing alcohol and they're seeking support and accountability. They will benefit from group therapy within an IOP program to help give them peer support structure and relapse prevention skills. And if a couple is reporting communication problems after infidelity, they will benefit from couples therapy to help them rebuild trust, improve their communication, and process the breach of relationship boundaries. Clients tell you what they think is the problem, but our job as clinicians is to dig deeper. Level of distress, functioning, and activities of daily life, relationships, are what help us to guide our diagnosis, our care level, and planning. We don't just treat symptoms, we treat their life. So, if a client is having issues with things like bathing, eating, or brushing, or even just getting out of bed, if a client can't manage those consistently, that tells us their level of functioning is impaired. And that will always influence diagnosis, treatment, and planning, and the level of care that we can recommend. So we have to assess the problem. What brings you in today? How does this affect your life? And what have you tried so far? This is the main issue that the client reports in their own words, documented use quotation mark, because this tells you why they're seeking help. Levels of distress refer to the intensity or urgency of the client's suffering and its impact on its functioning. So, and its impact on functioning. If someone can't complete their daily life functioning, they may need a higher level of care. like inpatient or residential. It also helps determine their functional level, high, mild, or moderate. On the exam, that can hit at severe depression, psychosis, or neurocognitive decline or trauma-related freeze responses. Remember, high distress levels require higher levels of care or immediate crisis intervention planning. We have to evaluate a client's mental health. Are they able to bathe? Can they go to school? Are they productive? Can they meet expectations? Um, how are their conflict patterns? Are they isolating themselves? Do they have any support system? Are they able to think clearly, problem solve? Is their memory intact? Are they a safety risk to themselves or other? And do they have insight of their problems? And are they able to make sound decisions? In a clinical assessment, functional level helps determine diagnosis, severity, the appropriate treatment modality, and a required level of care. This evaluation considers the client's ability to meet expectations across multiple life domains despite their symptoms. So, clients who are low functioning, they struggle with the basic self care, they cannot maintain employment or education, they experience severe social isolation, and they show poor impulse controls. Versus moderate functioning, they experience some difficulties maintaining consistency in work. Symptoms cause noticeable impairment, but client can function with support and accommodations. High functioning is client maintains independence in daily activities, employment, education, and social relationships. Symptoms may be present but have minimal interference with life roles and their responsibility. So this is a timeline for how you should screen for appropriate modalities. Are they using substances? Are they having psychotic symptoms? Is there any trauma? Do they have stable housing? And do they have a suicidal or homicidal intent? This is important. I mentioned this earlier. We can breeze on by to screen for depression, PHQ-9, BDI-2, the Beck Depression Inventory, or the Hamilton Depression Rating Scale. They help identify depressions, and anxiety is the GAD-7 we talked about. There's the Beck anxiety and the State Trait Anxiety Inventory. Those help differentiate between various anxiety disorders, and they measure the symptom intensity. It gives the clinician objective data to supplement clinical interviews. And then we have ACEs for trauma. We have PTSD um, from the DSM-5, which is the PCL-5. And then we have the trauma symptom inventory. They should be used when clients report past abuse, violence, or major emotional loss. They help identify trauma exposure and psychological impact, guiding trauma and helping with trauma informed treatment planning. This is important. This is the substance abuse. This is your cheat sheet section. So pause and take notes on the specific assessments for trauma, substance abuse, depression. So for substance abuse, they use the audit, the DAST, and the CAGE questionnaire. These tools show up in test questions all the time. You need to know what to pull out for depression, anxiety, trauma, risk, and substance use. If you're ever stuck on a question, ask yourself, what would I screen with first? And for risk evaluation, we already discussed the CSSRS, the Columbia Suicide Rating Scale, the Sad Person Scale, the HCR20. Those risk assessment tools should be used when clients mention suicidal thoughts, harming others or themselves, or if they have a history of violence. These assessments provide structured approaches to evaluating safety concern, and it helps guide appropriate interventions. Support systems can make or break a client's treatment. Ask about their circle, their family, their spiritual community. If it's strong, build on it. If it's toxic, address it with respect, of course. This also helps determine if group or family therapy is appropriate. Always reassess. Therapy should be goal driven, not just ongoing. Ask yourself if the client has a strong support system, if they need community resources, and if they have any professional support from healthcare providers. Okay? Don't forget to screen for health or risk to their suicide or the intent to harm. I want to leave you all with this. As a clinician, the way we assess will help guide how we interact with our clients. Intake and diagnosis is not about having all of the answer. It's about listening well, asking the right questions, and backing up your decisions with logic and the tools. The tools are your assessment tools. If something feels off, pause, consult the document. That's what makes you a good clinician. So, that's a full breakdown of our intake assessment and diagnosis. I apologize if this was long. This is 30% of our exam and is one of the most important foundations in clinical work. And it's a guaranteed area on the test. This is how you can keep studying smarter. Download the full flashcard set. It's available on my Gumroad page in this description video. It's in print and digital format. Join our Facebook group, NCMHCE Bible Prep, to study with others, to share tips and get exclusive updates. Follow me on all my socials at Social Catharsis and NCMHCE Bible Prep for daily nuggets, study reminders, and product drops. Your study strategy for this section: use the flashcards daily to reinforce terms like the mental status exam, co occurring disorders, and assessment tool. Practice reading short case blurbs and thinking, what would I assess? What tools would I use? And focus on clinical logic, not just memorization. Know how to recognize functioning level, risks, and next steps in care. This section shows up early in stages and early in the early stages of narratives. So mastering it sets you up for success all the way through the exam. And if you would like more information or you want to get the fast cards, look in the description below. It's also on Gumroad and join the Facebook NCMHCE Bible Prep. Follow me on all my social. And if this video helped you, leave a comment or share it with someone else studying. Let's pass this thing together. Thank you for watching. And remember, you are built for this. Let's go get this license.